Welcome to The Exchange, a series of rounds to drive change. This has been co-developed by Interior Health and the Canadian Medical Association. My name is Dr. Harsh Hundal and I will be your host for this session. I would like to first acknowledge and recognize that our work occurs on the 7 unceded, ancestral and traditional First Nations territories where we live, work, learn and collaborate together here in the interior of British Columbia. We would also like to recognize the Métis Nation BC, in particular the contributions of the Métis people to the diverse Aboriginal landscape of the interior. Today's presentation is Wellness, Resiliency, and Joy in Work, which I know is really front and center in people's contemplation as we come to this phase of COVID. Our presenters today is Dr. Marianne Morgan, Medical Co-Director of the COK Palliative Care Program, and Jessica Barker, Manager Clinical Operations, Seniors Care, IH. Neither of our faculty have anything to disclose. The only financial relationship is that we are sponsored by the Canadian Medical Association. With that, I turn it over to Jessica and Marianne.
So thanks, everybody. Well, Jessica's getting it organized here. Thanks, Harsh. And so I'm Marianne Morgan. I'm here with Jessica Barker. We'd like to tell you about our journey from worrying about compassion fatigue and burnout in our front lines to co-creating a team wellness program. And today we want to discuss our efforts to improve morale and decrease compassion fatigue and burnout in our palliative care teams. Jessica and I were privileged to be part of the first Interior Health DIAD Physician Quality Improvement course. Physicians and their operational colleagues chose a project and worked together. We'd like to tell you about our circuitous journey and how we landed on promoting team wellness. Then we'd like to ask you about how we might be able to spread this work throughout our health authority. Here's our learning objectives for the day. Especially during this past year, compassion fatigue and burnout are prevalent in healthcare at all levels. We hope to tell you about some of the very few programs in the world that focus on wellness strategies in the healthcare workplace. The challenge is co-creating the work with the front lines, not to them. By the end of our presentation, we are hopeful that you might take some of our ideas to your teams.
So where we started from, the Central Okanagan Palliative Care Team. It's an interdisciplinary team consisting of nurses, physicians, care aides, social workers, and multi-skilled support workers. We work across hospice and community settings to support individuals with a life-limiting illness in their last 6 months of life. Compassion fatigue and burnout have been anecdotally recognized within our team for years. And we've heard the consistent message that caring for dying people is hard. The evidence also supports the negative impacts of compassion fatigue and burnout in the health system. We were approached by a group of fourth-year nursing students from the University of British Columbia, Okanagan, and they approached us to work on a leadership project. And we tasked them to have discussions with our staff members about their experience and understanding of compassion fatigue and burnout. And their discussions brought up lots and really confirmed that compassion fatigue and burnout were real for our team. And the students also identified some of the underlying causes and categorized them into major themes that you can see on this slide.
This is the Physician Quality Improvement, or PQI motto. As I mentioned, we were in the second cohort, the first to include DIAD partners. Having Jessica with me was absolutely necessary for the success of this project. As well, showing up as a team to our various meetings has improved how we do palliative care. Here's our interdisciplinary group from our cohort and Jessica presenting our work to the teams. Our challenge, we thought, was to measure the amount of compassion fatigue and burnout in our teams, make some positive changes in the workplace, and then find a measurement tool to see if we were decreasing levels of compassion fatigue and burnout. We struggled with what we were going to do and how. Our project seemed kind of airy-fairy and overwhelming compared to some of the others in the group, such as decreasing the time from door to stroke treatment in the ER. We researched compassion fatigue surveys, and we found the professional quality of life scores.
So the Professional Quality of Life Scale, or the ProQual survey. It's a widely used and validated survey tool, so we thought, well, that's great. The research indicated it was easy to use, easy to score. It's been used for over 15 years, developed with data from over 3,000 people. So we thought we had really landed on a great survey tool to use. And here's what it looks like. This is the survey. You can see it's got 30 questions. It asks personal questions like, I get satisfaction from being able to help people, or I feel worn out by my work. And our initial idea was for our team to complete one survey every 2 months over a 6-month period.
Another of our challenges was to find time to meet with our multidisciplinary teams. There was no operational funding with the QI project or in Jessica's budget. At the same time, there was a new interior health documentation system that was being rolled out, and all the staff needed to be trained on. We were left with fitting in sessions during meal breaks. Ray Hill, who was our QI consultant, and I took pizza for lunch, dinner, and midnight for a couple of days to our hospice teams. Ray asked our teams to speak about what was difficult in their days and what that felt like. We then used this empathy grid that you can see on the screen that we learned about at PQI to stimulate conversation. Our staff were very appreciative of the face-to-face meetings. After the conversations, we introduced the ProQual tool and asked them to fill it out. We noticed immediately that some of our staff didn't feel very comfortable with the tool, and some actually had difficulty filling it out.
And here's a scatter plot. So a total of 42 staff members completed their survey, which was great. And so this is the scatter plot that actually represents the ProQual scores from our team's first round of surveys. The compassion satisfaction is represented by the green dots, the burnout is the yellow dots, and the secondary traumatic stress are represented by the pink. The vertical y-axis, that's labeled scores there. A high score is 41 or greater, and a low score is less than 23. So as you can see in the scatter plot, compassion satisfaction is actually overall high across the team, which was great to hear. But a lot of the pink and yellow dots are hovering around the 25 to 30 mark, which indicates a moderate level of burnout and secondary traumatic stress amongst our palliative team. And not surprisingly, clinical staff scored higher levels of burnout and secondary traumatic stress. At this point, we were happy because we had our baseline data, but we also realized there was no way we could get our team to complete this again. And we had originally wanted to do it twice. But we did really value and recognize the importance of summarizing the results and reporting back to our staff. We didn't want to disseminate this in just another email because our team, and I think we're all sick of emails. So we developed a summary infographic and brought it to our staff meetings. We talked about it in safety huddles, and we just explained our learning and results to the team. And it generated some great discussions. Two of our biggest takeaways was, number one, we observed and heard that by completing the surveys, that we were causing some distress to our team. And number two, that we actually really needed to shift the focus from compassion, satisfaction, burnout, over to wellness. So here's Marianne and I at our last physician quality improvement session. Although we're smiling in the photo, we were really struggling. With no operational dollars attached, we couldn't figure out how to fund our project. We also felt like our project was an outlier. So many of the other PQI projects had really clear aim statements with easily measurable outcomes. So we were feeling stuck. And one day, the social worker at hospice actually introduced us to the concept of moral injury. And we stumbled upon this video that captures the concept really well and helped us move along in the next step of our journey. And we're just going to take a moment and we are going to watch this video.
What's up, everybody? It's Dr. Z. Okay, listen, I'm really tired of people calling it burnout. what over 50% of healthcare professionals are experiencing. They call it burnout. It's exhaustion, low productivity, and a feeling of deep cynicism. And it's so prevalent that everyone, even in administration, is starting to panic. Like, what's going on? Why are physicians and nurses and PAs, why are they burning out? Well, burnout is a kind of victim shaming. It's saying you're not resourceful enough, you're not resilient enough, you're not strong enough to adapt to a system. So maybe you should meditate. Maybe you should use some lavender essential oil. Maybe we could have a wellness retreat or hire a chief wellness officer. Listen, it's all bull. Here's what's really going on. We're not suffering from burnout. We're suffering from something that Wendy Dean and Simon Talbot call moral injury. Let that sink in for a second. People go to war. They have a set of moral values. They care about other human beings. And then they're forced to either become a part of or bear witness to things that are so against everything they believe that when they come back, they fall apart. We call it PTSD. We have a million different names for it. What it is moral injury. Humans are moral, idealistic creatures that resonate love for other humans. And what happens when our moral ideals meet the real world, where we cannot give our patients the care we know that we could give if we had the tools and the resources and the autonomy to do it? What happens when we're trained in our schooling to give the best possible care to patients regardless of their socioeconomic status, regardless of their race, regardless of their condition or their gender, but then we meet the real world where it's all about the insurance company's bottom line. It's all about the hospital system's revenue. It's all about throughput and RVUs. And then we meet an electronic health record that is a glorified cash register with a little patient stuff tacked on. And we stare at that instead of staring at the vulnerable person who's having the worst day of their lives, and you can't be with them. How would that make anybody feel, let alone some of the most resourceful, resilient, passionate human beings on the planet, our healthcare professionals? These are people who went into this field with an almost evangelical religious zeal to help others. Why do I say that? Because they sacrificed their 20s, they sacrificed financial stability early on, they sacrificed family, they sacrificed sleep, they sacrificed their own health because they felt they were going to be part of something much larger than them. That is the highest aspiration of any human being, and they had a moral code to go with that. Then they meet our healthcare system, and all it is the opposite of what their morality tells them they need to do for patients. So what's going to happen? What's going to happen to a good person in a bad system when they feel they can't change the system, but they have to adapt? They're going to adapt, they're going to adapt, they're going to adapt, and then they're going to break. And that's what they call burnout. It's not burnout. The next administrator who tells you they're trying to manage burnout, tell them to go themselves. Tell them it's moral injury. And until we know what it is, we're never going to be able to treat it. How are you going to treat moral injury? You change the system that is causing the moral injury. You change the electronic health record to make it about bringing us closer to our patients, about making eye contact, about taking busy work off our plate. You change the conflict that drives us. Any given doctor on any given day serves three masters, at least. The patient, themselves and their family and their own financial interests, and their employer. And all three of those may be at odds. So how do you fix moral injury? You bring them in sync. We should be able to do well financially and well with our families and have time with our families while doing good for our patients. We call that Health 3.0, and it's where healthcare has to go. It means we need technology that enables the human relationship, that allows us to take care of the unique human story at hand. We need the tools, resources, and autonomy to do our jobs because guess what? Administrators don't know how to take care of patients. That's why we exist. Why do you think they call healthcare workers that are actually touching patients frontline healthcare workers? Where does that come from? The front lines of war. We use the language of war when we're taking care of patients, and we suffer the wounds of war, the moral injury, the PTSD of not being able to live up to our ideals. So the call to action is this: we on the front lines need to stand up to our leaders and demand that they lead, that they recognize that moral injury is something that needs to be taken into account, and we need to design systems and human systems that actually address that fundamental conflict. Stop putting Band-Aids on burnout and victim shaming suffering clinicians who are committing suicide at alarming rates. If you think this is a victimless problem and doctors and nurses are just entitled, privileged whiners, you can shut the f up, because people are dying. Good people, friends of mine, friends of yours have died from moral injury. It is not us. It is this system, and it's time we fixed it. The call to action is this: share this video. We need everyone in leadership, in government, in industry, and on the front lines to see this video. And let's stop calling it burnout from here on out. We out.
So I think, for both Marianne and I, we found this video really affirming. And we personally identified with the trauma that he talks about and also the call to action, and agreed that there needs to be shared responsibility for addressing moral injury across all levels of an organization and the system.
So we struggled with a framework to show credibility and prove that what we were doing was worthwhile. During our course, I attended one day of the BC Quality Forum in Vancouver. They had a whole day on compassion, fatigue, and burnout. I went to a talk by an internist from McMaster who was doing his PhD in QI, Andrew Smagus. It really fascinated me. His work focuses on categorizing quality improvement projects into Safety 1 and Safety 2 types and the importance of each. He argues that most QI projects, for a variety of reasons, are the Safety 1 type. Let me explain. So if you look at the slide, Safety 1 is the state where as few things as possible go wrong and problems are due to malfunctions and deviations. Because of this, the front lines are the source of malfunctions and deviations, and performance variability is harmful. Many projects suit this style, so making sure 2 IV medications aren't mixed up, decreasing door to TPA time in stroke treatment, for example. Safety 2 is the state where as many things as possible go right. You investigate all the outcomes, and front lines here, interestingly, are the source of flexibility and resilience. And performance variability is really necessary. This totally seemed like where our project fit. We needed our frontline staff to work with us to generate the ideas that would help our team. One of Smagus's other slides said, value people, value their expertise, listen to them. And another way to look at this in this graph, Safety 1 is the orange cog. If you were trying to prevent bad stuff happening, then you were looking for the one failure in 10,000 events. With Safety 2, you use what goes right to understand everyday performance to do better and be safer. Look at the 9,999 times that things went well. And so consequences of having all this Safety 1, the danger of focusing on Safety 1 fixes to healthcare. If you're looking at what's going wrong, you aren't looking at what's going right. So Smagus likened Safety 1 and Safety 2 to the dark and light sides of the force. You need both. The attitudes toward front lines really captured our attention with this. Often in healthcare, you get noticed if you do something wrong. There is not a lot of celebration for everyday good work. When you make any kind of changes in healthcare, therefore, you really need to be aware of the unintended consequences, positive and negative.
So the shift from Safety 1 to Safety 2 was significant for our project, and we finally had an evidence-informed framework that fit, and the confidence to keep innovating.
Another course I signed up for was the Institute for Health Improvement's Joy in Work. The title really stood out to me at the time. Joyful wasn't a term I was using to describe my workplaces. Interior Health funded me for the 8-week virtual course, which was fascinating and uplifting. Over 800 people from across the world were in my group. iHigh makes the argument that if people enjoy coming to work, They will make less errors, take less sick time, and give better care. The Institute for Health Improvement has a comprehensive white paper with all kinds of great ideas on how to make your workplace better. They suggest asking questions like, what matters to you? And this really started getting us to reframe our language on how we talk to and with our colleagues and our employees.
Joy in work entails that leaders create a space to listen, understand, and involve colleagues in providing input into decisions. And it's a purposeful shift from passive relationships to more active engagement with your team. And the shift in thinking enables a better understanding of the barriers and also allows for the co-creation of meaningful, high-leverage strategies to address issues. Here's iHigh's framework for joy in work. And it shows that there's actually kind of 9 core components for ensuring a joyful and engaged workforce. The 3 outer rings show who's responsible for these components. So you can see senior leaders, managers and core leaders, and individuals. The senior leaders are responsible for all 9 of these core components. Managers and core leaders are responsible for 5, and then individuals for 3. And the responsibilities depicted are meant to help leaders assess and plan for ongoing development of behaviors and systems at all levels to improve and sustain joy in work. So using the framework of Safety 2 and joy in work, we shifted the focus of our project and our work from compassion, fatigue, and burnout to team wellness. To move that forward, we held a palliative team dinner last year. This was pre-COVID. And this event was funded through the Kelowna General Hospital Foundation, and we had over 40 team members attend. At the dinner, they broke off into groups and came up with fantastic wellness strategies that would actually be a fit for our team. And here's another summary infographic of the ideas that they came up with. So examples of wellness opportunities that we've made available to our team over the last year include the UBC SMART training program. So that's UBC Stress Management and Resiliency Techniques training program. It's an 8-week mindfulness course, and it's researched and managed by UBC. And actually several departments within UBC have adopted the course and adapted it into their curriculum. Our course was facilitated by a palliative nurse who has had her own experiences with compassion fatigue and burnout. And over 35 members of our palliative team actually took the course. And we've heard really positive feedback and on the value of this course in their own lives. And we've really observed positive impacts in the workplace too. We weren't able to fund this course with operational dollars, so we obtained funding through the foundation. And we also connected with a spiritual advisor at Kelowna General Hospital. As you might expect, acute care has also observed high levels of compassion fatigue and burnout. So from that, they developed a 4-hour diffusing and operational triage course, similar to critical incident stress debriefing. Myself and Marianne took the course, along with a few other members of our palliative leadership team. We found the content highly applicable to our setting. But the challenges were really about scaling this up. There's lots of other competing mandatory training courses that our employees and staff need to take. And again, the lack of operational dollars to actually send each team member to a 4-hour course was a huge barrier. I just want to point out, and you can see here's a text message, and this text message was sent out to us by one of our palliative nurses. And she sent this text after she had attended one of our engagement sessions with myself, Marianne, and our QI consultant, Ray. I'll give you a moment to read the message. And for us, it just really highlights the impact of this work and just how important it is to learn from the people and the system that you're trying to improve. Good news, too, across the palliative portfolio, overall sick time's down. And our biggest win is hospice sick time, which is down almost 50% from last year. And our overtime is also down. Hospice was a group that we were most concerned about because they're at highest risk for compassion fatigue and burnout. And for us, from a QI approach, the decrease in sick time is potentially an outcome measure and or balancing measure for our project.
So most people are familiar with the triple aim. And since the iHi team introduced the triple aim into healthcare lexicon, this concept is spread to all corners of the healthcare system. It's an approach to optimizing health system performance. It proposes that healthcare institutions simultaneously pursue 3 dimensions of performance: improving the health of populations, enhancing the patient care experience, and reducing the per capita cost of healthcare. iHi recommends that the triple aim be expanded to a quadruple aim, adding the goal of improving the work life of healthcare providers, including clinicians and staff. So we put together how we feel our palliative team wellness project has shifted from safety 1 to safety 2 here. In retrospect, we feel our QI journey started with a safety 1 mindset. We were reacting to our concerns about compassion fatigue and burnout. We collected data with a burdensome survey that focused on the negative. We planned to impose training. We have shifted to a more proactive approach. We plan to collect data that informs our team as well as ourselves. We're trying to propose instead of impose, and we're seeing signs that our work is making a difference.
So the joy in work, and the white paper specifically, has some great examples of really easy strategies to implement. So examples are expressions of gratitude at your team huddles, asking what went well today, what could have gone better. I also want to draw your attention to the going home checklist, which is just that photo on the left on the slide. And it's actually from a hospital in the UK. The signs are placed in staff rooms and staff see it as they're leaving at the end of their day. And the signs really follow the joy in work principles, and it would be a cheap and easy thing to implement. We also have a few committed staff members who have approached us, who have a passion for the work, and they've established a palliative team wellness working group. And we've also made recent connections with the leadership team from the emergency department at Kelowna General Hospital. So we have a unique opportunity to really spread and scale this work locally. But from an operational lens, funding is often a barrier to implementing wellness programs, but it's doable, and we've learned some strategies which require money and which ones don't. In the day-to-day, we implemented some of the joy and work strategies at no cost whatsoever to the system. For example, saying thank you, offering kudos to your team members, and modeling gratitude in the workplace really did and continues to improve overall team happiness. The foundation for us was an excellent source of external donor funding that we were able, and I'm grateful to have been able to tap into that for opportunities for our team. But at the end of the day, operational funds are required to build sustainable wellness programs, and the investment also demonstrates to teams that we are invested in their health and their wellness. As we move forward, we are looking to build palliative team wellness and build a program and to scale and spread within the central Okanagan, the first stop being Kelowna General Hospital. We've made some exciting connections kind of nationally, and this is with a researcher and clinical psychologist from the Ottawa Hospital. And in a recent teleconference, we learned that they have a fully embedded wellness program at the Ottawa Hospital. For example, they have a peer-to-peer buddy system and have integrated wellness into their onboarding processes. They're utilizing a national framework that was developed by the Department of National Defense, and it's called the Road to Mental Readiness. The Road to Mental Readiness is a resiliency training program, and it's aimed to improve short-term performance, long-term mental health outcomes, to reduce barriers to care and encourage early access to care, to provide the tools and resources to manage and support employees, and to assist supervisors in maintaining their own mental health, as well in promoting positive mental health in their employees. So you can see here the mental health continuum model. So that's the stoplight kind of figure here with the green, yellow, orange, and red is one of the central components of the Road to Mental Readiness. And they've also developed a really cool app for their employees to use. They're keen to share their resources with us and their learning, and we're excited to see where this connection could take us and our team. And here we are, still in COVID times. So during the pandemic, and still to this day, we have seen a wide range of moral stressors and outcomes. But we've also seen positive moral emotions: compassion, pride, gratitude, and support for healthcare staff, physicians, and teams in managing these stressors is essential. And the responsibility needs to be shared across all levels of the organization, beginning with healthy and effective teams and systems.
Sorry, just lost my screen. Okay, in summary, we wanted to reiterate the value of the physician quality improvement process. We've had access to expertise and funding for physician time and spent valuable time together as dyad partners. The process also allowed us to move our starting place and take different paths. We've had success and failures, but we've made progress and learned lots along the way. We found our Safety 2 framework, a place to hang our work and our thoughts. And we love this diagram here on the journey and the circuitousness. So what next? Building healthy, joyful teams must come from within the teams, and organizations have to support this work. And we're really hoping that your thoughts and suggestions might inform where we go from here.
So one of the challenges here that really comes up is the operational dollars to be able to do that. You manage to work sideways through the foundation. How do you see that? There's the dollars, but there's also the time. Where did the staff get the time to be able to, 4 hours of training, et cetera, on top of it, everything else that's going on?
I mean, I think operationally that we need to build in that time too, and that needs to be prioritized. So to carve out space for employees to be able to take these learning opportunities. So perhaps not even, for the mindfulness course as an example, that was after hours. So it was something that they had to do above and beyond. And so that's a high barrier for me, a high barrier kind of initiative. So how do we create the opportunity for them to perhaps take this during their work day, for example, and enable better ability to take advantage of some of these opportunities?
And the other thing that comes to mind is the buddy system that Ottawa has, that they built in from the beginning into their orientation. Your thoughts regarding that as a way to actually transfer culture and knowledge?
Yeah, I think we were really looking at what we could do in terms of the onboarding process. And I think you could do that at all levels, physicians and every other staff.
I think the other thing we really love about that, the peer-to-peer model, is it's very bottom up. And so for me, so generating that from your team and being excited about that and carrying that work along and, shifting that mindset moving forward, I think is really great instead of that kind of top-down approach.
Can you tell me a story about someone whose mindset shifted, who you found at the beginning, quote unquote, really injured, and what they went through?
Yeah, I think we could tell a story of a couple of our team members who actually have become really integral members of our palliative wellness working group. And they were two of our palliative nurses who came to us and just really explained how they were feeling with the compassion fatigue and the burnout, and have been working in these jobs for a long time. And we're both ready to quit. And we're kind of at their rope's end. And really became excited by this project, joined a lot of the opportunities. So taking the mindfulness, being engaged in a lot of these discussions, taking the survey, talking about it with their colleagues. And as they were doing this over the last year, as they were, talking amongst themselves, they started making a connection between the two of them and both recognized that they were in similar, situations. Both had been at this job for a long time. Were both feeling ready to go and leave the palliative team. But because of that shared understanding and the shared experience, we're able to start opening up and have these conversations in a kind of a safe space. And then felt able to come to Marianne and myself and to share that. And then to talk about how can we spread this amongst the team and then how can we kind of change the system kind of moving forward. So I think they're great examples of that.
Yeah, I think there's quite a few examples. I'm thinking about the nurse who taught our smart mindfulness programs. When COVID came along, those were suspended, but she continued to host Monday evening sessions where anybody who'd taken the program could sign on, and she continued to lead those. So I think the more connections you make with people, the more opportunities come up. And yeah, I think we haven't done a cost analysis, but I think there's lots of opportunities. And I think the biggest changes come from how you speak and treat each other, not on expensive programs.
Now, there's that respect element. There's also gleaning from this the idea of you don't want, it's not about people buying in, it's about people investing.
Yeah.
You know, our staff are actually the investors in care. And when they stop investing, everybody loses. So it's bringing back that sort of desire to invest of themselves again. Mike has a question or comment.
Oh, thanks, Harsh. I hope you can hear me.
We can, Mike.
Great. Well, thank you. What a perfect way to end the exchange series, to have this this talk. I certainly needed to hear this today and over the last year. First of all, Jessica, nice to meet you, and Marianne. I've known Marianne for years, but I wanted to thank you for the work you do in palliative care. There's no better work in medicine than palliative care, in my opinion. But and thank you for the presentation. It was excellent, and thank you for recognizing PQI. I've heard about this project from Devin Harris, but to see the presentation is very special. So thank you for that. I have two questions, and you can answer one of them, whatever you prefer to answer. But Marianne, you and I have been around for north of 20 years, so. If you knew then what you know now, and we just recruited 3 physicians today coming to IH who are youthful and just starting in their careers. So Jessica and Marianne, if you knew then what you know now, what advice would you give these physicians? And the second question is, there's talk now in the literature about a 4th wave with respect to the pandemic, and a significant proportion of that 4th wave is to do with mental illness and wellness as related to the pandemic. So how do you see this work helping the organization and our colleagues in that theoretical 4th wave? So either question, but thank you again for the presentation.
May as well start with the first one first. I think it depends what size of a community you work in. The warmth and the way that you join a community. We work in a really big tertiary center now, and it's easy to get lost in it. So I'm the department head for family practice. I've got more than 200 family docs that I privilege. I've never met a good portion of them, and there isn't really any way for me to reach out at the moment. So I've been thinking about this quite a bit with that, is how could we do a better job when they come to the community of reaching out? And there's all kinds of ways in terms of here's our information, but how do we do that warm handshake where people feel welcomed and they feel like their ideas matter, and we give them that. And I think a buddy system would be a really cool idea too, if they don't have that already. Jessica, you got anything to add there from?
Yeah, I think it's that call to action to embed this from the beginning. Like if I were to look at I'm a nurse, is my background, and if I were to look at when I started in the field to now, it would have been great to have some of this learning to carry me through my career. I feel like I've been doing a lot of, self-reflection, trying to gain these skills over the last few years to sustain myself in my career. So, to start with those skills, and then to know that you're going into systems or organizations that will keep fueling you and looking out for you and your health and wellness as well, I think are going to be really key. I'm pleased to see that UBC, for example, has embedded the SMART mindfulness program in a lot of their curriculum. And I know that from the nursing perspective, but I can't speak to the physician piece, but I think it's those pieces that I think are going to be really integral. And so that our employees and physicians and nurses and others can have the voice to say, I need X, Y, Z in order to keep going, and that we hear them. They feel valued, and we're being responsive to what those needs are, I think are important. And I think that kind of feeds into your question, Mike, about the fourth wave. I also, am more concerned about that, and I can see I'm in it. I've been 2 months in an outbreak setting, and I am tired. And this third wave really crashed hard for myself, my team, and I can feel it all around. So to think about a fourth wave when we're already feeling exhausted is worrisome. So how do we get ourselves there, and take on this fourth wave?
And
Yeah,
Jessica
thank you. I sent that survey out to the physicians because there's a lot of things in the literature about people in healthcare just kind of hanging in there until this is over, so to speak, and then accelerating their retirement or decreasing their FTE. And we I think we sent it out on a Friday, and by end of day we had over 400 responses, and now we're up I think close to 900. So like it's north of 33% response rate, which the best surveys usually have 27%. So that's telling me and telling all of us that this is something that our medical staff want to talk about, and it'll be really interesting, the results. But what you're talking about right now will be really helpful for me and our team with our medical staff. But I'd love to hear your comments on this because it's a bit of a game changer, isn't it?
Yeah, and I think there's ways to do it wrong and ways to do it right. We've both been watching as the hub comes out each week with these mental health supports and suggestions. And I can't speak for everybody, but for some of those, they felt weighty. It's like, oh God, you want me to do that too? And so you really have to be clever and careful about how you present information to and engage people and make them feel supported and not. I think, and that's why we showed that moral injury video. He speaks to that so well. You can't just stick a Band-Aid over something for people that are hurting, and how do you respect that?
Yeah.
And one of the things we learned too is that it is so important to really know the teams. There's not going to be, a blanket solution for everybody. We're all unique. We all have various needs. And so different strategies are going to work for us in different ways. So and that's definitely what we heard from our team. And as we've been presenting this work, we're seeing that kind of play out, and we're seeing that feedback too. So there needs to be kind of a multi-pronged approach. And even that IHI's Joy and Work framework really speaks to that multi-pronged approach, but being cognizant that it takes there's a lot of core components to the Joy and Work framework.
And it's not lost on me. I'm sure it's not lost on anybody that the team presenting this is a palliative care team. So you're dealing with patients who are palliative, and you're teaching us about Joy and Work. So that's pretty special. So thank you.
And you have demonstrated outcomes in terms of sick time and whatnot. I know at the moment we're doing a medical staff onboarding project through RCCBC, and part of that is the buddy program. I know that Vancouver Coastal has introduced that as part of their orientation, but I totally agree with you that should essentially be, you should have a buddy the moment you show up at IH. And one of the things that I think you've probably experienced is that if we have injured people modeling for new people, why are we surprised that new people pick up on that, right? Why are we going, oh, they're anti-IH or they're putting so-and-so down, right? We shouldn't be surprised if we haven't already lifted up and helped heal the injured. Mm-hmm. Glenn asks, he wonders if the fee-for-service payment model for physicians contributes to moral injury, in where you are too busy focused on overheads and not enough focus on time out to engage in wellness.
Yes. And the whole electronic medical records, Glenn's my generation too. So how do you type, for God's sakes? And yeah, how many patients do you have to see in a day to pay your overhead? And even though MSP has increased I'm going to speak for family docs, our abilities to do different types of billing, there's 16,000 different things you have to remember if you want to get paid the same as the person next to you. So yeah, from an MSP model, it's very difficult.
And on the staff end, as well as affecting physician, are targets that are set. You know, you need to be able to move so many patients through particular programs or ALCs, et cetera, the lingo that sort of dehumanizes the experience.
Yeah, I think those are the systems pieces that, you know, that video really kind of highlighted. And yeah, we lose the human side of it, that human centric, which is who we are, why we're all here. We lose the why, and we're focused on metrics and outcomes and numbers and EMRs and yeah, all the things that can really start to drive that moral injury.
So I'm going to ask you, what is if you were sitting or with the board or with our senior leadership team, what would be your advice to the leaders in interior health? So I'm going to break it down. Start at the top, then look at the executive directors and directors, and then the PCC on the floor. What would be your advice to each of those levels in terms of creating more wellness? I know, tough one, Harsh.
I think you'd need to give us a little bit of time to come up with an answer to that one. I think it goes back to that. It really depends on the team, and I think what's been challenging us and what like the Joy in Work course specifically shows us, and I think our own work is you got to start with your own team. So you need that support from the people making the decisions up here to give the teams the support to co-create and experiment and try things out, and maybe have a little bit of a budget for some fun games they can do, and supportive work, you know, mindfulness courses. But it depends what that team needs, so that not everybody in IH needs a mindfulness course, because not everybody wants that. So I think it's allowing groups on the ground, the front lines, to create in their group what works for them, and having the resources to do that. So the more middle level have to know what those resources are, or enable other people to provide them, and maybe go looking at how much do these apps cost? Could we provide something like that? Could we have a roving team that goes around to some of these frontline groups to help support and provide information and guide? And I guess at SETS level, once we made those ideas on what we might invest in, would you invest a little to support those things that make a difference?
So
yeah, that's it. Jessica. I agree. Yeah, I think again, I think we've seen the success of that very bottom up approach, but absolutely need to have the approval and the push from kind of the senior executive that this matters, that this work matters, but it definitely has to be built, I think, from the local levels, and then brought forward to say, this is going to work for the Central Okanagan, or this is going to work for the palliative teams across the health authority because of X, Y, Z.
I think we both hesitate at saying which things at the moment, because we haven't had, Jessica got seconded to Cottonwoods, so we haven't seen her in several months, because she's been on outbreak. And so we haven't talked to the Ottawa hospital in a year. So we'd really like to restart those conversations, see what their program looks like. East London Hospital has a whole health authority that's embedded this kind of work. So I think it would be an excellent idea to be very specific about which things to invest in prior to making any of those decisions. So I don't think I'd recommend anything right now until we could do more research.
And I think part of this is there's a tendency in quality improvement safety 1 to stamp out variability. This actually says that it's the variability, it's a local nuance that is the strength. And how do you feed it, right?
Yeah. And it takes time. It takes time to feed that too, and space and kind of patience and work in order to have that grow.
So in terms of your scale of time, how long did it take from when you started having those pizza meetings, those dinners, etc., what was the span within which you noticed in terms of your outcomes that changes were happening, measurable change was happening?
I would say with the focused work, it was all probably over the time span of a year. But if I really look at to the pre-work that we were doing without really knowing what we were doing, what the path that we were heading down, that pre-work is building the relationships, building the trust within the team, and coming and recognizing that, okay, this is something, and here's an opportunity. For us, it was the physician quality improvement was the opportunity, but it had been building and ideas had been generating probably a year leading up to it, probably even longer if we think about the anecdotal observations that we had with the team about compassion fatigue and burnout. But when we really started to then, PQI was our catalyst, and it gave us more focused time and expertise to be able to really focus on this project. It's been over the last year and now kind of into 2 years. But I've been so thankful to have had this pre-COVID, because I think it has made our team much more resilient. And it's not to say that it hasn't been hard. It has been hard with the palliative team too in COVID. But I do think that we have seen the value of having a resilient team ride this pandemic and ride the waves.
And that, in my conversations with individuals across IH, teams that were having challenges functioning before COVID are having even more challenges at this point. And teams that were well functioning are still well functioning teams, and some of them are actually functioning better at this point because they've created that atmosphere, that environment of trust, and people having each other's back in terms of getting through the day and actually still being able to laugh and appreciate and have gratitude for what they are involved in. So thank you. Have a great evening. Once again, I'd like to acknowledge the support of the Canadian Medical Association and Interior Health in giving us the opportunity to spend this time together and have our presenters here. I'd like to again acknowledge that we have met on the traditional and unceded territories of the 7 First Nations of the Interior, and acknowledge the contributions of the Métis of BC. Thank you. Take care.